My name is Dr. Louise Wen, and I'm an anesthesiologist at Stanford Hospital. In today's video, I'll share with you my approach to outlining the anesthesia oral board stems. And I came up with this idea because as a resident, I really had no idea what I was doing before the mock oral boards, and I would get the piece of paper with a stem, outline, circle a few words, make some random notes, and hope for the best. And that was not a good approach. And it wasn't until the final mock oral boards that I had that my examiner said, Louise, you really need to have a systematic approach before you even enter into the room. So she shared her structure with me. I've since adapted it to a way that makes sense for myself. I look forward to sharing that with you in this video, and I really hope you find it helpful. This is the stem that we're going to use for this exercise. Pause this video, take a few minutes to review the stem, and then when you're ready to proceed, resume the video. Now we'll review the overall structure of the outline. So first we break it down by system. So there's neuro, cardiac, pulmonary, GI, endo, and miscellaneous. So this section for her would be pregnancy. If, for example, she were getting a kidney transplant instead, this would be the renal system. Then we further break it down by problems, medications, preoperative workup, anticipated complications, monitors, induction, notes, and then a final check. Now we will focus on her problems. In the neuro system, she's scheduled for an emergent cranie. She has Cushing's triad. She's somnolent, she has a C-collar on, and she has periorbital ecchymosis. For the cardiac system, she is very severely hypertensive. For the pulmonary system, she is hypoxic, requiring significant FiO2. She has loose teeth. The GI system, she's full stomach. She has no real endocrinological issues known at this time. And then for pregnancy, she's pregnant and she has preeclampsia. Let's take a look at medications. For her, it's pretty straightforward. She's not on any known pre-medications, so we can skip this section. Let's look at her preoperative workup. I'm assessing what medications, imaging, and lab results are indicated prior to proceeding to the operating room. So by system for neuro, I would do a focused history and physical exam, assess her pupils, calculate her GCS score, review her CT scan of the head. For cardiac, I would assess her volume status, being concerned about hemorrhage and intravascular depletion in the setting of preeclampsia. I would review her EKG and the results of her CBC, CMP, coags, type and screen, type and cross, and urine protein. For the pulmonary system, I would review her airway exam and her chest x-ray, paying close attention to any pneumothorax or rib fractures. For GI, I would assess her ultrasound fast exam. Nothing is really indicated for endo. And then for the final column of pregnancy, I would call an obstetrician to assess for perioperative fetal heart rate monitoring, consider alerting the NICU, and then think through the pros and cons of betamethasone. So that has the advantage of fetal lung maturity. However, that also has the risk of perioperative hyperglycemia. And then I would think through the tocolytics. So magnesium has the advantage of maternal and fetal cerebral protection. However, it could cause worsening neurologic depression, which may affect the postoperative neurocheck. And then terbutaline is also a tocolytic. However, it is a beta agonist, and she is already critically hypertensive. Now let's look at anticipated complications. So I spend the most amount of time in the anticipated complications section. For neuro, I would expect elevated intracranial pressures. I would be concerned about neurogenic pulmonary edema, diabetes insipidus, cerebral salt wasting, and C-spine injury. For cardiac, I would be worried about venous air embolism, arrhythmias, hypotension or hypertension, myocardial ischemia in the setting of severe hypertension, and potential hemorrhage, and think through whether or not ROGAM would be indicated. For pulmonary, I'd be worried about pneumothorax and difficult airway. For GI, she's at very high risk for aspiration. For endo, she would be at risk of having hyperglycemia, especially if she's gotten steroids. For the final pregnancy section, I would think through diagnosis and treatment of amniotic fluid embolism, emergent cesarean section, preeclampsia evolving into eclampsia, postpartum hemorrhage, and neonatal distress. Let's think through what monitors are indicated. In this patient, I'll have standard ASA monitors, including a 5-lead EKG an additional IV for volume resuscitation, an arterial line, and a central line. And then I would think through my answer if they were to ask me if I wanted to place a pulmonary artery catheter. I would also have a Foley, a core temperature monitor, discuss with the surgeons whether or not SSEPs and MEPs are indicated, and request for fetal heart rate monitoring done perioperatively. Now we'll think through how we will induce this patient. In this section, I think through whether the arterial and central lines have to be placed pre or post-induction, if I am going to intubate this patient awake and what my plan is for topicalization and sedation, or if I'm going to intubate her asleep, if I'm going to use an RSI, which opioids, induction agents, and paralytic agents I'm going to choose, and what technique I'm going to use if I should run into a difficult airway. And especially for this neuroanesthetic case, I'm going to think through the implications of my IV anesthetic versus a volatile anesthetic on MEPs, SSEPs, cerebral blood flow, and cerebral metabolic rate. And I would also be concerned about the issues of nitrous, especially if she were to have pneumothorax. And I also do a final internal check at this point on whether or not regional or neuraxial techniques would be an option. And if it is, what my backup plan would be should the block sedation plan fail and I need to convert to a general anesthetic. Now we'll review the notes section. This is where I'll place her vital signs, her lab results, what imaging studies she's had, and additional notes to myself. So for ICP management, I would write down CPP equals MAP minus ICP and how to decrease her ICP, including sitting her up, increasing ventilation for how long and to what goal and tidal CO2, having judicious PEEP, and mannitol furosemide. And any other additional notes would go here. At this point, I do my final check. I do an overall assessment of what I filled in so far in my outline, and then I think through what patient, surgical, and anesthesia problems I might have forgotten. So I hope you found that helpful, and I look forward to seeing you next time.